Yeah, brilliant. I'll start because we're tight for time. Good morning, everybody. Thank you for joining this webinar today, developed with the team at Polybalm, but with collaboration with UKONS. And delighted that you could join this morning. I think we've got a really interesting agenda for you. I'd like to welcome our two key speakers today, Professor Rob Thomas, who's consultant oncologist at Bedford and Addenbrooke's hospitals, a professor of exercise and nutritional science at the University of Bedfordshire, the oncology lead for integrated medicine at UCLH, and a author of a number of publications, including the book How to Live. Rob, we're delighted that you could give us the time today. Thank you in advance. And I'd also equally delighted to have here Hasna Dufour. Hasna is a breast cancer survivor and patient advocate living with the condition for 20 years, having been given 18 months to live, and credits her survival to pioneering clinical trials in immunotherapy through the Royal Marsden. And she's here, which is really important for us, I think, to give us a view on her lived experience in her journey, and including with her nail care. If you have questions, please do add them to the chat, because my able colleague Jonathan Slobon will be monitoring those, so we can try and address some of your questions today in a Q&A. I will also attempt to address them all in a follow-up if we don't have time. And with that, I'm going to hand the floor to Professor Thomas to present to us on managing nail toxicities during systemic anti-cancer therapy for the next 25 minutes. And then we'll come to Hasna to give us her perspective as a deep dive into the patient experience. Rob, can I hand over to you, and I will advance the slides for you.
Thank you, Dave, and well done everyone for getting up so early for the webinar. I can see there's quite a few people joined, and more people joining all the time. And also thank you, Dave, for taking on this product following our research and making it available across the world. So, you know, the practical side of things is very important. So yeah, as Dave said, I'm a working oncologist working for the NHS full-time, doing breast and prostate cancer. And more recently, I've just started working in UCLH as head of integrative oncology. So it's a passion I've had for a long time about how to support patients through their cancer journey, not only getting better outcomes, of course, shrinking the cancer, but how they can tolerate it and reduce the impact of quality of life. So next slide, please. And then next slide. So just before we start, I mean, we've all got nails, so we know what they look like. You know, they're quite a complicated structure. Now we have the hard part, you know, the nail itself, but most of the sort of hard work of where the nail is formed is in this sort of matrix just below the cuticle, where that's where the rapidly dividing cells are located. And those, you know, when you give someone chemotherapy and other therapeutic agents, it's any tissue which is dividing rapidly gets affected. So you get the bowel being damaged, and patients get diarrhea. You get the bone marrow being affected, and you get neutropenic sepsis. The cornea can be affected, and you can get dry eyes. So it's a similar process. It's because the cells are dividing rapidly in the nail bed. They're more vulnerable to damage. Next slide. So why do we need nails? I mean, it's pretty obvious. Most of the time is through evolution we've developed them for protection. It also apparently they help the dexterity and grip. And because they add a firm plate to your feet, they actually help with balance. And obviously, in this day and age, we have nails because they look nice as well, and they're quite glamorous, especially if they're if they're in good quality. Next slide. on a medical perspective, nails are supposed to be the window to what's going inside. If they look pale, we know the patient could be anemic. There's certain deformities like spoon-shaped nails, which could reflect iron deficiency. In our training, we're all told to spot clubbing nails, which could be a sign of lung cancer and other cancers. And even if you see little sort of splinters in the nails, little red hemorrhages, it could be a sign of infection of the heart valves. So, it's important. We're always told when we're, in medical school, when we're examining a patient, we always start by looking at the hands and nails. So they're, very important structures. Next slide. So, we're all familiar with the fact that nails can be damaged during chemotherapy, but the old school of examining patients seems to have gone a little bit. There's lots of remote consultations where we're not seeing the patient, and it's very obvious that nail damage is underdiagnosed, and the impact it has on patients, because it's not often life-threatening. So oncologists are often talking about, do you have infection? Do you have any bleeding? Do you have diarrhea, or even now with sort of lung toxicity, etc. So, it's often not even asked. And even in clinical trials, people have underestimated in the past the recording of nail damage. Next slide. And we know it, we know from, this is a very good paper published, which shows that, this reflects my experience. It's over nearly 50% of people on chemotherapy will have some effect on their nails. Chemotherapy such as taxanes are more common, but it can occur with other chemotherapy agents. But more recently, as we've moved into the biological domains, you can see it now with TKI inhibitors and some monoclonal antibodies, and even more rarely you can get damage from hormonal therapies. So it's things like tamoxifen, etc. Usually you don't get it quite as severe, but it's actually for longer periods of time. So the effect of the person can be equally annoying. Next slide. We did a study we presented at Mask in Adelaide quite some time ago now, where we asked patients what were the worst things about their chemotherapy journey, and fatigue seemed to be number one. Nausea was quite common, but nail damage was sixth on the list. So it was quite if people looked back to their regimes, we asked the question, what was the most uncomfortable feature of your treatment? And sort of there was 30% of patients said that nail damage was the most uncomfortable feature of their treatment. So it's obviously very significant. Next slide. This was a more recent paper. I think Dave was on this journal as well, where we looked at, again, how it affected patients and the awareness of nail damage to the oncology team. Next slide. And it sort of reflects. This is a very recent paper. I think this was published this year. So you'd sort of think with increased communication amongst oncologists and patients that awareness of nail damage would have got better since the paper I just described in Adelaide a little while ago. So this looks at the patient's experience. So we knew when you asked a patient, about 90% were aware that you could get nail and or hair loss. When you split that up, you said, well, how many were aware of actually hair loss? It was about 81%, but how many were aware of nail damage? It was less than 50% were aware of nail damage going into chemotherapy. Were they warned about nail damage or hair loss? Well, surprisingly, 50% of patients weren't even told about hair loss, but less than 20% were actually advised about nail damage. And then even more worrying, did they receive any practical advice to reduce the severity of nail damage, and it was only 11% of patients. Now, for something which affects 50% of patients, it's a bit of a it's not very good that we're less than 11% are actually given any practical advice about it. Next slide. Next slide, Dave. So what actually happens, there's nail damage is a sort of, there's different severities. Bowes lines are the classic, where you see ridges, which you can see from the second picture on the right, where you get ridges and dents in the nails, and that corresponds to the cycles of chemotherapy. And they can be a little bit, they're not usually painful, and patients don't usually mind them that much, although cosmetically it's not that nice. And then you can get dark patches or stripes, or leukonychia, which is white scratches, which again, not too troublesome in terms of pain. But then as it gets more severe, you can get subungual hemorrhages, which then are uncomfortable. Now, disruptions in the nail anatomy can then lead to infections called paronychia. And now this is actually quite serious, because this is actually then leads to an infection, and you could have to dose reduce or stop the chemotherapy. And then eventually you get complete loss of the nail bed, or most of the nail, and the nails can actually come off. Next slide, please. So as you can imagine, the impact of the quality of life changes can depends on really how severe the nail damage is. But as soon as what patients often describe is that their nails feel very sensitive even before you see the damage. They say they get very sensitive, they can't do up buttons, typing is difficult. It can affect their sleep, because of course their nails start throbbing at night and being uncomfortable. And if it's in your feet, it can affect your ability to mobilize. Now, obviously, the secondary effects of that can be quite severe, because we want patients to mobilize during chemotherapy. If you don't, you're going to get increased side effects, fatigue, and increased thromboembolism. So, it's not just about the cosmetic. There are some serious consequences of having nail damage. And not just that, there's enough for patients to get through when they're on treatment, and having something which can be prevented is a shame, because you can get low mood, you can get low self-esteem. Patients might not want to go out and mix with people if they see their nails look damaged, and sometimes they can get quite smelly as well, when there's secondary infection. So it means they stay at home, and it's the worst thing you should do. We want people to go out, we want people to mix and socialize. Next slide. And this is some of the things we'll hear from Hasna in a minute, but a lot of these are sort of what patients are saying. I expected hair loss, but I didn't expect nail damage. I hated people looking at my nails. It even hurt to wash my hands and put on clothes, and it can catch on clothes and be uncomfortable. Next slide. So this is not a new trend for us being interested in nail damage. This is actually now 16 years ago when we first started realizing in our cancer unit that this was a problem. And this was a nice little experiment we did, where we got a patient to put one hand in a bucket of cool water and the other hand just normal. And we looked at nail damage after 3 or 4 cycles. And there was a significant difference between the hand which was being cooled and not cooled. And I think this was one of the first studies ever published looking at that we could actually reduce the incidence of nail damage. But unfortunately, it's not very practical. And I think the health and safety officer was a bit upset with me putting patients' feet in a bucket of cold water and then connecting them to the sort of electricity. So that's not something which we would advise or catch on. But next slide. So you can, but there are commercial devices available now for cooling, and you can buy them, or you can buy things off the internet. Not particularly practical in a busy oncology unit, and sometimes the nurses don't like them because they can you can't see the hands, so you can't monitor the patient as well. And I did have one patient getting a bit of chilblains when she kept them on too long. So, they help, but to have a practical solution like Polybalm would be a lot more easier to deal with. There's lots of myths around this. People say you should paint your nails black. To be honest, I mean, even though you hear it every day, there's no real evidence for this at all. People are putting on essential oils themselves, which they're buying over the counter. The trouble is, essential oils can actually be quite damaging, and they can irritate the nails and make it worse. Generally, moisturizing the nails is a good idea, but again, a lot of evidence for this. People can take biotin supplements. Again, the evidence in healthy people not on chemotherapy is limited. It can affect blood tests. You've got to be careful. Men on, we know that biotin affects PSA levels. And as I said, there is some evidence for cooling devices, but not massively practical. Next slide. So we decided back in 2013-14 to try to form a team together to see if we can develop a practical strategy for reducing nail damage. So we got some nurses, oncology, patients, herbalists, dermatologists, complementary therapists, all working together. And we came up with the fact that many natural products, botanicals, in careful concentrations, could have natural properties which would seem obvious to help the nails. So a lot of them have anti-inflammatory properties. We know that many essential oils have antibacterial properties. So when the nail is damaged, a lot of the secondary damage is caused by fungus and infection. And it can help that. We know that they have antioxidant properties because they would be a local antidote to the chemotherapy. They can help analgesia, and they can also moisturize. Next slide. So anyway, long and short of it, we worked together for quite some time and came up with a series of basically botanical essential oils which have anti-inflammatory, antioxidant, antifungal, antibacterial properties. And just as importantly, unlike most creams available commercially, we didn't want to mix these creams with petroleum-based bases. So we wanted the base to be of benefit as well. So we used organic beeswax, unrefined organic shea butter, and things like cocoa butter. So the whole complex was completely natural, and even the bases had a hydrating and anti-inflammatory addition to it. Next slide. So we wanted to find out whether it worked. So we designed a double-blind randomized trial involving 60 participants. We dealt with statisticians from Coventry at the time, and they felt that 60 patients was enough power due to the fact that nearly 50% of the people would get damage. And we looked at various parameters of damage. We developed a strategy of applying it to the nail bed, and we used this sort of applicator, which you could not only massage it, but you could push it into the cuticle so that you get a good layering of the cream. Next slide. So the patients were either men with prostate cancer or women with breast cancer. Most of them were on taxanes, and they were equally balanced in the two randomized groups, whether they'd had, how many cycles they'd had. Next slide. And we used 3 endpoints. We used a dermatology quality index, and we used the best one. We used a nail psoriasis symptom score. So there were 2 questionnaires, and we also took photographs before and after and sent those to 3 independent doctors to look at the photographs and grade the toxicity. Next slide. And it became, when we started looking at the results, it became very obvious that if you were on placebo, well, we didn't know at the time because it was double-blind randomized, but when we put the photographs together, it was very obvious if you were on placebo, you continued to have, and placebo was just a petroleum-based balm, which looked very similar. It looked, nail damage was pretty much as we expected. About 50% of the people had quite marked damage. Next ones. Next slide. And then what was very reassuring was that when they were on the Polybalm, there were still some, ridges and some mild changes, but there was a very significant difference that most people on the Polybalm did not have nail damage at all. Next slide. And then if you put that numerically, so the dermatology life quality questionnaire, there was a very highly significant difference between the placebo and the Polybalm. I mean, these were amazing p-values of, p less than 0.0005 difference. The linear scale was significantly different. In fact, the linear scale, interestingly, went up. So a proportion of people felt their quality of nails had improved despite the chemotherapy. So there is no doubt there was a very highly statistically significant difference. And next slide. And put it sort of practically, what it means is that of the 29 or 30 people on the Polybalm, 27 got no nail damage. They might have seen some slight changes. There were still one or two, and this is what we need to say, there were still one or two. There was one man who had quite marked damage, but he actually ended up in intensive care with profuse diarrhea and neutropenic sepsis. So I think the level of Taxotere in his system, and he'd had something like 16 cycles of Taxotere as well. So it will still, you still get damage in one or two, and but there's certainly less than it would have been if they hadn't have used it. Next one. And we're very pleased that we presented this at ASCO and published it in Breast Cancer. And also, it was an honor to be featured on the front cover of the journal. So the journal felt the paper was of such significance. It was put as the leading article that month. So yeah, so that was nice to see. Next slide. Clearly what the trial showed us is the earlier you use it, the better. So, ideally, certainly in Bedford, where I lead the chemotherapy unit, patients are given Polybalm before they start treatment as part of their pre-treatment conversation. Every patient's given about 45 minutes to talk to a nurse to run through all the side effects. And of course, we include nail damage along with neutropenic sepsis and hair loss and all the other things. And they're advised to use it, even if they're on, say, EC Taxotere, where you don't see much damage when you're on the EC, but we advise them to use it right from the start. And that's clearly where you get the best results. But it's never actually too late to start because, and unfortunately, what tends to happen is people around the country, people start their chemotherapy, they see the nail damage, and then they start Googling what I can do to prevent the damage. Now, a lot of the damage has already been done, but there is anecdotal cases where even if you start using it after the nail damage has started, you get a quicker recovery. And certainly it's more comfortable because the nails are more they're more moisturized and there's less splitting and less secondary infection. So it's never too late to start it, but of course I would strongly advise trying to use it right from the beginning. Next slide. So I don't know if Hassan's not going to talk about this, but one thing we do explain to the patients is it's best if it's used at least 2 or 3 times a day. You need to really sort of rub it into the nail bed so you can push the moisturizing element and into the nail itself. It's supplied in 2 tubes, one for the hands and one for the nails. We've got generally not advised to use the one on the nails to the hand, so you don't get cross, if there's any fungus, they get cross infection. So yeah, so it's a practical device, and we've had some fairly reasonable feedback that it seems to work okay. You can rub it in with your thumb as well if you like. So it's thank you very much for listening. I mean, I can see we've got 140 people there. So clearly there is interest in nail damage, and I'm really grateful for Dave Almond to take this product forward and make it commercially, because as a unit we can't do things like that, and I'm very grateful for the organization of the conference to highlight it in this webinar, and I'd be grateful to have some questions later if you want.
Yeah, so we'll catch the questions in the chat, Rob, and we'll come back to you if you can stay with us. That'd be amazing. And thank you for walking us through that really interesting presentation and your deep experience, of course, clinically in this area, which is really invaluable to us. So, and then if everybody on the line does want more in-depth support, then of course on the website there is a CBD approved course you can do free of charge. Now, in the clinicians section of the website, there are also patient materials, and you can always contact us. We'll do our best to respond directly if you have questions, and we can go to Professor Thomas if there are questions that need that expertise to address them. And with that, I'm going to now turn to Hasna. Welcome, Hasna, and thank you. We are very, very grateful for you to join us today, because in the world of healthcare, nothing more important in the end than the patient experience and the patient perspective in the mix of the medical expertise to help the patient. And so we really want to hear about your journey. And I know you want to express that partly in a really a well thought through poem that you've put together, which I'm going to come to in a second to hear that poem for everybody today, because it really gives us the emotion and the insight as to how it feels to be a patient, and in particular in this case the nail challenges you suffered. But before that, just to set the scene, before we get into that, I'm eager to hear that, but I want to, before that, just get very briefly at least your background, just so that people can understand the deep experience that you've endured through your journey, and how successful you've been in that journey. And I know you've experienced some side effects on the way, including nail damage. Give us a couple of high level scene setters, if you like, before we come to the poem.
All right. Hi, good morning, everyone. I'm so happy and privileged to be part of this experience this morning. Thank you very much, Professor, for passing through that slides. I'm listening to it again, and I'm totally feeling as if it's something that belonged to somebody like me, Anyway, some background about me. So I was first diagnosed with breast cancer in 2006. So this year is 20 years. I've been navigating breast cancer, family life, In 2017, I was diagnosed with stage 4 cancer and given 18 months to live. So far, I've been on 5 different clinical trials at the Royal Marsden, and currently, I am on the trial that I'm on has been stable for nearly 5 years, which has given me the space to sort of understand what really happened to me within those last 20 years. I mean, listening to the information, I really suffered a lot with nails, and nail toxicity, just nail damage, without even having a word to say what that meant, So when I had the first workshop with Polybalm, and I heard things that made sense to me. It was just one of those things that made me feel very much like, this is my nails. This is what's been happening. I didn't know what was happening. But I mean, I'm a big patient advocate for especially things that are not within the chemo world, within the cancer world, that's not loud, that should be very loud. And yeah, that's a little bit about me. I'm a mom of 3 children. I'm very happy about that. And I'm a grandmother as well. And because of clinical trials, my life has been extended. So I've been able to sort of be around to take part in life still and be happy.
So, well, congratulations, Hasna, on an amazing journey and the success. You're looking wonderful, and we're delighted to have you with us. So, with that, can we all just sit back for about 4 minutes? I think it's going to take. But Hasna is a writer. She likes to write to express herself, and I read this poem, and it's very moving. So please listen to her words, and it will give you insight into the emotions that a patient can feel in relation to her nails in a difficult journey.
Yeah. All right. So the poem is called At My Fingertips. I cried over my nails. Imagine that. After cancer, after chemotherapy, after 20 years of treatment. It wasn't the diagnosis that broke me. It was my hands. Hands that once plaited my daughter's hair. Hands that comforted. Hands that carried my life. Then they hurt. Every touch felt like fire. People look at my nails and saw something cosmetic. I looked at them and I saw 20 years. 20 years written quietly with my fingertips. I remembered sitting in my oncology appointment crying, thinking, why am I crying over my nails? But I wasn't. I was crying for every little thing cancer had taken without asking. Then someone spoke about nail toxicity, not in vanity, not as something trivial, but as something that mattered. For the first time, I felt seen. Today, I can place my hands in warm, washing up water. It sounds ordinary until you spent many years unable to do this. Sometimes healing doesn't arrive with a big fanfare. Sometimes it begins at your fingertips because surviving matters, but so does living, and quality of life matters too. My nails are important. Thank you.
That was wonderful, Hasna. Well done.
Thank you.
And yeah, no, that I think just to underline that. No, I know. You spend a lot of time to capture that in a few powerful words, but it really does bring it to life that these things do matter. They can sound trivial when someone says, "Oh, you might get some nail damage," and then ignore it. But actually, that is not the way things should be, as you have expressed. So,
yes,
those words resonate. I hope with everybody today that it does matter, and it can be something we can manage. With that though, I know we met at a patient forum, and
yes,
I talked, mostly around the issue, not just about Polybalm. But you seemed that day, if I remember, you seemed that day to be almost it was an epiphany, right? Oh my God, oh my God, somebody's actually talking about this. I've been sitting around for 20 years and no one's talked about this to me, which made me feel good, by the way. But with that, you then started to say, well, I'm going to try some Polybalm that the team at Bedford had developed with Professor Thomas. And if you could just, I know it's still early days, it's a few weeks you've been doing that, but I think that's been enormously helpful. But could you just describe so far how that's been helping you overcome this particular challenge?
Okay. So, I just want to bring back to that workshop. When I came to that workshop, I was like, okay, there we go. But the name, nail toxicity, I was like, that's my hands. So everything, as you said, it literally was an epiphany, because as a patient, I've been through many different things. And as a patient, I sort of always left the nails and just sort of say, that's on a lower level. But because of the amount of things that I was having, but not knowing that it was behind here. So when I met you all and everything, I felt so to use the product. But one of the things in using the product that from the beginning, so I have flare-ups in my nails. I have splits in my nails. So sometimes they get very infected. Everything that the professor said, I had my nails sometimes being very smelly, which had affected me a lot going out. But over the years, I had different ways. So I would hold my hands in different ways so that people wouldn't see or experience. But starting to use the product from day one, I was in a crisis. And from day one, the throbbing on my nails had stopped just by putting it on the top. It was so sensitive just to even use and that applicator is perfect. But when I started using it, immediately within and this may sound as if I'm selling the product. I'm not selling the product, but I just want you to understand what it did for me. My fingers stopped throbbing that night. And I was like I couldn't even believe it, So I went to bed, I put gloves on because it was in a bad situation. And in the morning, when I looked at my nails, it was as if it was magic. Honestly, it was something very magical over the night. And from since then, it's just been better. I have not had, it's about 6 weeks now I've been using the product. I have not had any flare-ups, no infections, and healthy nails. I couldn't comb my daughter's hair. And that was one of the things that was every day I have to do that, you know what I mean? And every day the hair was going inside of it. Within 3 days, we were like, and she was like, Mama, you're not saying anything about your nails. So the product in itself, it's extremely good. And I believe also that the natural components in it, it's what's doing the work, for the nails to be better. I can now touch my hands. I can now click my fingers. I can do a lot of things that I've never been able to do. And it's Polybalm, I'm going around the place telling everyone, can you look at my nails now? Can you look at my hands? And it might sound as, very small, but the confidence levels for me has come back, with that.
Thank you, Hester. And actually, what's important for me is that, credit to Bedford and Prof. Thomas and the team for doing the clinical trial, the randomized trial. But in the end, it's in the real world, hearing that actually you're finding that to be such a benefit is equally important, because it's the lived experience, and we get reaffirmed that this is really helpful. So we're very grateful to you. We're gonna move on to the Q&A in a second. I think hopefully for everybody on the call, the coverage there from Professor Thomas on the problem and the unmet need, if you like, the clinical research, the development of alternatives to try and address this, and then hearing that come to life, and that wonderful poem, Hasna, thank you, really valuable. So if I could perhaps now, just watching the clock, we're on time. If I could ask Jonathan, and maybe Jonathan, if you can hear me okay, maybe it's best that you read them out rather than us, you and I trying to determine questions. And if you read the question out that you've seen coming in, I can direct it then either I'll answer it if it's for me, but it's more likely for Professor Thomas or Hasna. Can you hear me, Jonathan?
Hi, yeah, can you hear me?
Yes, we can hear you well, yeah.
Good. I just think that it's really important to highlight, Hasna, the feedback we're getting for your poem is fantastic. You've really touched a nerve. And the line that people have really honed in on is surviving matters, but so does living. And this has really resonated with the nurses. So yeah, well done you. I think you've encapsulated their motivation and the patient's feeling in half a dozen words. Incredible.
Thank you.
So the most popular question that's coming through is where can they actually buy Polybalm, and is it available on prescription?
Yeah, so I'll answer that question, Jonathan. So as you all know on this call, this is an educational meeting. It wasn't here to be a direct, marketing exercise of the product, but to answer the question specifically, go to polybalm.com, and you won't just be able to get the product through polybalm.com. You will find on polybalm.com that actually we centered our efforts on education. So you will find CPD accredited course, which is 8 modules, 80% pass rate, no pressure, to get your certificate for revalidation. And you'll also see patient materials that you can have in soft copy, or you can order them, and they're free of charge. So there's a lot there for ongoing education and patient support on the site. And you can get the product there. If you do buy the product from there, by the way, we give to cancer charities £1 every time, and we've actually given some very significant donations to the cancer charity community, who've been equally helpful in supporting Polybalm where patients can't afford it. Across the whole of the UK, we have about 20 patient groups supporting that. The other thing I would then say is, and don't hold me to it, but there are 4 NHS trusts buying Polybalm now through the NHS stores, not through clinical pharmacy, and that is discretionary, and that may improve over time. We will work on that because we've done a lot of work on value for money, showing, and we published that at ONS in San Antonio, showing you can actually save money as a trust if you manage this problem. If anybody wants that data, we can share it with you. But I will also file this product to the Borderline Substance Committee, who manage with nutritional supplements, etc. And if they ever approved it, of course, it would go on to an FP10. But the probability and the chances of that prescription is to be determined. So I can't promise. What I can promise, though, is between patient self-help, NHS trusts, private sector, and patient groups, we will continue to make this availability more seamless for everybody. I hope that helps. Jonathan, next question.
How long does one go on?
Sorry, go ahead,
Dave.
Rob,
Just
sorry.
clicked in there. What we did in our trust is we did manage to get some bought through our charitable support. Patients donate money, and we did feel that was the MDT and the trust did feel it was appropriate use, and we bought some, and then we give it out free to the patients. But there's always pressure.
Yes.
There's always financial pressure on that. So yeah, that's another way around it, is you get donations to your cancer unit, and you can put some money towards it, and you can then give it to either patients free or at substantially reduced cost. So that's another sort of route in if anyone
and
has
actually, Rob, we followed your model there. We found nearly 20 really proactive patient advocacy groups who have supported it either directly or through the trust across the UK. So that's growing, and we'll continue to find avenues, including some direct purchase from stores. We've seen that in several hospitals now. So that's things are improving. Jonathan,
how long does a pack of Polybalm last?
that's an easy one. It'll last at least a month. Using the 2 tubes, one on hands, as Rob said, one on toes. Just keep them separate. Nothing will grow in the product. It's anhydrous or oil based. It's not water based product. So it's not so much that the product will grow bugs. It's just that keeping the 2 tubes separate, because you have a higher probability of fungal infections in your toes if anybody does. So just use them separately twice a day, and you'll get at least a month out of a pack.
Yeah. We don't assess nails. How would you suggest we go about doing this?
Rob, do you want to start with that? I just have a quick comment on it afterwards, but yeah.
Well, there is a standard toxicity score, a Linkit 5 scale. In the trial, we used a psoriasis questionnaire and a dermatology questionnaire, which was quite extensive, really. I mean, it was looking at whether it's painful, whether it kept you up at night, did it catch you? I mean, I'm not one for loading more administrative tasks on our overworked nurses and doctors. So if you're doing a trial, for sure, you need these formal questionnaires and photographs. But I think the best way is just to talk to the patient every cycle and say, look, how are things affecting you? And I think it would be good to at least do the National Cancer Institute 5 scale grade. And sort of get into a habit of doing that, along with diarrhea and fatigue. But it depends how interested you are. If you wanted to do a more formal prospective audit or surface evaluation, I would recommend the psoriasis score as the number one question.
And just to add then, Rob, that sets this up very nicely. We've just completed some analysis of available tools, including the ones you mentioned, for practical implementation in the front line. So the paper you mentioned earlier in your presentation regarding the survey of patients and the gap in knowledge on this area concluded actually in the section at the back that there was a key role here for frontline specialist nurses to educate and to provide those frontline assessments. And because of the current assessment tools for side effects either don't address nail care adequately or they sort of don't mention it at all. Okay. We would recommend. We've actually developed a draft frontline tool. We're looking for centres or individual clinical experts to help us develop that further and evaluate it or validate it in clinical practice. We're willing to support that, and we would then publish that and see if we could get that integrated into routine clinical care in the United Kingdom and beyond. So if anybody's interested in that type of research, including yourself, Rob, we've done a bit of groundwork, and we're very keen to work with experts and UKONS to see if we could advance the consistency and quality of frontline assessment in clinical care, if that makes sense.
Yeah, well, that's nice to hear, Dave. Thanks, because as I said, the ones we used in the original trial, one was a psoriasis score and one was a general dermatology score. So to have a specific oncology nail toxicity score would be very useful if it's quite straightforward and doesn't take a long time to fill out.
Yeah, it's intended to be a triage tool, so we'll take it offline. But Hassan, it looks like you might have a comment on that.
I just wanted to say something. So, from a nurse to patient aspect, so a lot of time is spoken about your hair and do this and cold treatment and different things like that. Just the initial questioning in the beginning, in your diagnosis or your first meeting, that's a point that needs to be addressed so that we don't have people who don't have an idea of what's going on, because you know what's going on with the chemotherapy, you understand that, but then holistically you don't have a clue of what's going on. So if you hear certain things, if these things are mentioned in the beginning as standard form of care, not only focusing on the hair loss, to me, and the nausea, different things like that, but something that's very specific like that, because it affects patients. It affects you within the same time that the chemo goes into your body. So from that space, I think that initial conversation as nurses or people within the field, that should be part of it very, very strongly moving forward, or in your daily basis. Even today, it's something that you should talk about, because if you speak to a patient, they don't have a clue. We don't have a clue. We just see the damage.
And Hasna, that just underlines, I think, what we should do next. We'll take it offline for today, but we should, someone can help me clinically to get that tool ready and validated, and then my goal will be to get it used routinely in every centre in the UK. So every patient deserves healthy nails, right? In their journey. So let's take that as a follow-up. And Jonathan, I'm watching the clock. We have 6 minutes. I need 2 minutes at the end. So there's time for perhaps 2 more questions.
Sure.
We'll answer the rest offline anyway.
So Hasna, you were ahead of the game there, reading the room incredibly well. But following on from what you've just said, there's a question here saying, as a patient, what would you like to hear at those early stages about your nails from the nurses, because they don't want to overwhelm you with information?
So, I mean, just as I think the amount of care that goes into when you talk, especially to women, about losing their hair and stuff. I mean, just generally, what I like to hear is these are things that could happen very quickly. So then the nurse gives the patient that sort of information, because we are ready for nausea, but we are not ready for nail toxicity. You know what I mean? And I think having that information, just being able to share, well, you can have extreme nail damage, or you can have a little bit of nail damage. It all depends, but it's a conversation that needs to happen within a trusted environment, within you and your nurse, because it's one of those things that from the beginning, it makes it known, I really wish I had this product from the beginning. And I really wish that I had those conversations from the beginning. So, I mean, nurses, you all know what to say, because it's individual patients, it's individual humans. So you all know exactly what to say to the patient. But yeah, just make sure and have the conversation.
Excellent. Agreed. And Jonathan, we've got time for one more question live, if possible.
Yeah, and it's all around the same theme. One is actually coming through quite quickly at the moment, is that people are saying UKONS should help us develop an online, a frontline assessment tool, which is really reassuring. But the other thing is, why is nail damage not spoken so much? And I think this is more a clinical question rather than the Hasna. So it's the opposite side of the response you've just given.
Rob, why do you believe it's just not on high enough on the list? Given what you presented on the mask data, showing actually it was 5th or 6th rank as in some cases 30% of people saying it was my #1 issue, but yet we don't seem to talk about it. So it's a bit of a there's a bit of a mismatch here. Why do you think that is?
Yeah, I mean, it's very difficult. I mean, as a unit, we've always been designing trials and doing surveys, trying to find out what really matters to patients. So we've done a lot of work on, fatigue, whether they should be exercising, weight gain, nails, and unfortunately, amongst many oncologists, and the nurses are certainly better than the doctors, but certainly from the doctors, they tend to concentrate on the things which are sort of life-threatening. So they talk about profuse diarrhea, neutropenic sepsis. And with the new biologicals, there's lots more to think about, because there's new side effects which we weren't having to sort of deal with. It's like pulmonary toxicity, cardiac toxicity, peripheral neuropathy. So I think there's just a lot to talk about, and they tend to just prioritize the life-threatening ones. And because it's getting more complicated, it's not getting any better. So things like nail damage, fatigue, weight gain are still not being talked about enough. And I think it's a worry that you're overloading the patient at the beginning. But, most patients now starting chemotherapy do have these, have a reasonable period of time with a very highly trained oncology nurse to go through the various things, and they don't all have to be said right at the same time. You can give lots of information and come back to it at different phases. So you can do it, and we do it in our center. But I think that's what I think is just they're prioritizing the serious things, what they see are the serious things first, and not looking at the things which affect the patients. I don't know if Hasna agrees with that.
We're up on time, guys, so apologies. I don't want to cut you short. We've got 1 minute, and I know people will want to jump onto the next part of a busy day. Hasna, have you got one sentence you want to add before I close out?
I'll just make sure that we get this information across the board. UKONS, all the people, just what we have to do, just make sure to do it. And cancer care has to be holistic. It has to be the whole patient, not just only one part. And
agreed. And with that, we're right up on the 9 o'clock. I want to thank Professor Thomas and Hasna, our experts here, experts from a clinical perspective, experts from the patient experience, lived experience indeed, perspective, and that wonderful poem. Thank you for bringing it to life. As I said, there are educational materials out there on polybalm.com for nurses and patients. We give educational talks. Just let us know. You can email me or Jonathan at care@polybalm.com. We're like travelers. We go all over the UK presenting in every cancer hospital in the UK on this topic, not just on Polybalm, but on the whole topic, because our goal is that every patient deserves healthy nails during their cancer journey. And we will achieve that not only in the UK, but worldwide if we keep working together to highlight this area of unmet need. And we thank you, the audience, for your undivided attention today and taking a chunk of time to listen. I hope you found some useful insights out of this last hour. And with that, I'll close out, and have a great rest of the day, everybody. Thank you so much.
Thank you then. Bye.
Thank you.
Okay, bye.
Thanks, guys.